Hello, everybody. Thank you for inviting me to do this presentation. And this is really to share my experiences as a rural physician in presenting and spreading the word for the Choosing Wisely list. So this is my health district. It's in rural Queensland, about an hour away from Brisbane, and it's called Darling Downs. We have a population of about 300,000 people, and we have about 20 hospitals in our district. We're also known as the Garden City, as you know. We love our parks and gardens. So just to recap, the top 5 evolved list, which is the top 5 choosing wisely in palliative care. The recommendations are that we should consider early palliative care referral for people who have life-limiting illness, early advanced care planning for this population. We do not recommend oxygen for people who have non-hypoxic dyspnea, and we would encourage oral-assisted feeding instead of percutaneous feeding for people who have severe dementia. And the last one would be a routine medication review when starting new drugs. So I've been able to be fortunate enough to present the Choosing Wisely list for palliative care in various groups. So we presented to medical students, junior doctors, medical registrars, advanced trainees, specialists, and I was also very lucky enough to be able to present it with a Queensland group of palliative physicians. We were still also able to present to general practitioners and also nurses, both community as well as hospital-based. And the uptake of that was a very positive response. So this is one of the remote areas that we actually traveled to actually do the presentation. So we used a lot of the case studies to highlight each recommendation, and I think that helped a lot, especially for junior doctors as well as nurses. And we were also very fortunate to actually, have a very good support from the college that they were able to provide us handouts. So I didn't put that in picture, but handouts that actually put in the top 5 list. And if people wanted to learn more, the rationale for each of the lists, and if they wanted and was very keen to actually know more about it, they actually have a list of all the evidence. So that there was a very good uptake and a lot of visibility regarding this. The feedback from the audience was that it is a good list. From very junior levels, medical as well as nursing-wide, to fellows, there was a very good uptake. And they actually felt that it was a very relevant list. It's clinically relevant, and it would change clinical practice. It's also very current. One of the other things that we've got feedback from is that it integrates well with other specialties. We have been very fortunate that the respiratory physicians have actually been very supportive of the recommendations that we had. The geriatricians and the medical oncologists were also very supportive of the the recommendations that were included in the list. And it's a work in progress because having 1, 2, 3 lectures is not going to be enough. So we are planning to do a continuation of it. And as has already been mentioned earlier by different speakers, is that I'm also targeting the younger generations, because I think in the last year that we have been presenting, there's been a good cultural shift, though it's not a very big one. But our medical students who are now interns, the interns who are now junior doctors, and the junior doctors that are now medical registrars, they're actually been, prompting the more senior doctors to say, oh, why aren't we doing this? Because this is what the recommendations are. And I think all of us learn from each other. So the nurses are prompting the GPs, and I think the feedback from the nurses is that we wish you could spread this word out more. To other specialties, but also to other, populations, so allied health, and and also because we work rurally, so there's also a very good intake from the community health team regarding the list. And there's also a call to action that every one of us can make a difference. I think for me, There may be one person, all throughout my lectures that said to me, whatever you say, I'm not going to do it. But then out of that one person, there's so many other people who have actually looked at it and changed their practice. So clinical impact of our district is that we now have an integrated project for advanced care planning, and we've also had a dramatic decrease in funded oxygen in palliative care. We've also had a lot of collaboration, and there's a lot of excitement from other subspecialties, such as renal, to actually form an early integrative palliative care program, such as a renal supportive clinic. So we're now doing a business case for that. And, points to ponder is that people want to choose wisely if they know what to choose. This is a work in progress, and we have to call an action. We can all make a difference. That's it. Thank you so much, everybody.